La conférence d'aujourd'hui est rendue possible notamment grâce au soutien du CIUS de l'Ouest de l'île et également à l'unité de transfert des connaissances, soit SynapTiC. SynapTiC a été récemment mis en place, en fait, il a été mis en place tout dernièrement. Derrière SynapTiC, il y a toute une équipe, en fait, qui coordonne, accompagne, planifie et organise les conférences auxquelles vous assistez. J'en profite d'ailleurs pour les remercier, les féliciter aussi pour tout le travail qui a été accompli et leur belle réalisation. Cette unité, qui est SynapTiC, donc, tentera au fil des mois et des années de répondre à un important mandat qui est celui de contribuer à véhiculer, à transmettre et disséminer les savoirs et les connaissances. Nous vous invitons donc à rester à l'affût de nos prochains événements, donc au courant des prochains mois, prochaines semaines, et à les partager dans vos réseaux personnels et surtout professionnels. Alors, sans plus tarder, notre présentateur et notre présentatrice aujourd'hui sont donc le Dr Sajjan Paul, chirurgien de la colonne vertébrale de formation internationale, actuellement candidat au doctorat au département de chirurgie expérimentale de l'Université McGill. Également, Dr Antonia Annert, professeur agrégé à l'École des sciences infirmières Ingram de l'Université McGill, membre associé du département de chirurgie division chirurgie expérimentale, ainsi que du département d'oncologie de l'Université McGill. Membre associé également du Centre de recherche St. Mary's et chercheuse associée au CIS de l'Outaouais. Excusez-moi. Donc aujourd'hui, la présentation aura pour titre, oui, Using Augmented Reality in Spine Surgery. Donc, nous vous invitons à poser vos questions à la fin de la présentation seulement. Vous pourrez les poser soit par écrit dans la section chat, donc la boîte de clavardage, ou verbalement. Nous activerons les fonctions de caméra et de micro à la fin seulement pour qu'on puisse vous voir et vous entendre. Pour les questions écrites, donc, notre modérateur, et même pour les questions verbales également, nous aurons comme modérateur M. Zumanan DB, qui s'occupera notamment là, de poser vos questions à haute voix et d'interagir, de contrôler, disons, la séance de questions à la fin de la présentation. Donc, voilà pour moi. Donc, Dr. Paul, the floor is yours. Merci beaucoup.
Merci. Thank you, everyone. Thanks, Sylvia, for a nice introduction. So, I would like to share my PowerPoint. RB, would you please give me the access to share? I'm not having the access to share the PowerPoint.
You have your share button on your right, left.
Yeah, it is saying only meeting organizers and presenters can share. Can you give me the access? Yes, now I have.
You got it, okay.
Thank you.
Can you share it?
Yeah. Now I think it's working.
Okay.
Can you see?
Yes.
Yes, but you need to put it in
Yeah.
in presentation mode. Perfect.
Yes. Thank you everyone for your patience. So today my talk is about the use of augmented reality in spine surgery. And as a part of team, I would like to introduce Dr. Anthony and Dr. Debe. And so I'm going to start my talk on the topic. Today's, in terms of my talk, our agenda is divided into clinical observation and current practices, imaging in spine surgery, projection of imaging data, augmented reality, innovation, and future of surgery. So in terms of the clinical observation and current practices, on the 25th May 2021, a breaking news came into the air, and one Franklin County woman reported that her surgeon operated on the wrong side and even on the wrong part of the spine.
Swayan, there is no sound.
There seems to be no sound.
Okay. So in this presentation, I'm sorry for the sound problem because it's not, the Microsoft team is not having the sound from the video. So in this presentation, the Franklin County woman reported that her surgeon operated on the wrong side and wrong part of her spine. And in the clinical story, he has mentioned that the country woman has found that even after doing the revision surgery, she is having more having the back pain. So in terms of the spine surgery, spinal fusion is a surgical procedure which will connect two or more vertebrae in any part of the spine. And in this procedure, surgeons often use the pedicle screw and rods, as we are showing in this picture, to fix the spine. So in terms of the clinical situation during the operative procedure, correct placement of pedicle screw is very challenging. The neurovascular structures are obscured during that time because surgeons cannot see where the nerves and vessels are located at that moment when they are operating from the back. And this situation increases the risk of operative error. So in our current practices, when surgeons are doing the operative procedure, surgeons need to look back into the imaging data of the patients to locate and to find that where he needs to place the pedicle screw. And often he needs to shift his attention from the surgical side into different mirror or screen where the radio imaging data is going to be projected. So now let's look back that what are the current practices is ongoing during pedicle screw placement. At first, it was about two-dimensional fluoroscopy-based navigation. In this procedure, when scientist has examined, we have found that 84% of the pedicle screw placement is having the accuracy. So there are 16% of the revision surgery rate. And in this procedure, we are having more surgical duration or the operative time. When it moves into the three-dimensional CT scan based technique, when we can do the three-dimensional CT scan, moving from our previous two-dimension to the three-dimension, we have improved the pedicle screw placement 91%, but the three-dimensional CT scan needs more chances of the radiation exposure. Now, the world find the robotic intraoperative CT scan-based navigation. It gives surgeons 95% of the pedicle screw placement accuracy, but it lacks the active intraoperative three-dimensional image guidance because it is not having any active intraoperative component. So it is having 5% of the error rate during the pedicle screw placement. So now we will look back into the imaging technology in the spine surgery. What are our imaging techniques we are going to use and how it can help in spine surgery? So as we all know that X-ray is very convenient and it provides only the two-dimensional images, but it is unable to provide any complex anatomical visualization, and it always takes a static image at a given time point, not a dynamic imaging system. And in terms of ultrasonography can provide dynamic real-time images, but it is also two-dimensional presentation, and during surgical procedure, it can have interference from surgical instruments. In terms of CT scan provide real-time images for a spinal procedure. It can give both two-dimension and three-dimensional presentation of imaging data, but it needs the optimization of perioperative CT scan to use during surgery. And in terms of MRI is most expensive imaging system for the operating room because MRI uses magnetic field and radio waves to provide the detailed images. It is costly and as well as the time consuming since the surgical instruments are made of metals, so they can interfere with the magnetic field. So if we want to use the magnetic resonance imaging in the operating room, it cannot be possible in the same operating room. It needs to be done into another area and then come back with the patient into our operating theater. So in this presentation is going to be an interactive poll. So I would like to share your opinion and know your opinion that what would be the best type of patient's imaging data to project during surgery. So you can go to the slido.com and use this code to give your opinion. It seems everyone is saying about CT scan as the best type of patient's imaging data to visualize during surgery. And it is true, like the 3D CT scan is the most appropriate data for intraoperative visualization. So if we think that, yes, we will use intraoperative three-dimensional CT scan, so how we are going to project that imaging data in terms of spine surgery procedure? So before going into that direction, let's go back what we are currently doing. We have in the operating room two mode of display. One is heads-up display, where the surgeon needs to look into the mirror or the screen where we are showing the operating procedure. So as I am showing in the pointer, like the surgeon needs to look at that area to know about the intraoperative visualization. And it is two-dimensional skin, so that data that is going to be projected here is having only the two-dimensional capacity. And in terms of another aspect, we have head-mounted display, which is having two areas. One is optical see-through head-mounted display, and another one is optical non-see-through head-mounted display. So with the head-mounted display and heads-up display, the main difference is with the heads-up display, it is only visualizes the imaging only the two-dimensional space. In contrast, the head-mounted display can visualize the imaging into the three-dimensional space. So when we are visualizing through the heads-up display back into that two-dimension skin, all the data are going to be projected having two-dimension value. And when we are going to project it through head-mounted display, either optical see-through or optical non-see-through, these are going to be into the three-dimension coordinate system. And we would discuss a little bit later about augmented reality and virtual reality. So optical see-through head-mounted display is mainly used for augmented reality purpose, where non-see-through, it is used for the virtual reality capacity. So in terms of, I would like to know your opinion that what would be the best way of presenting a patient's imaging data during surgery. Do you think that head-mounted display is the right, which is going on now, or do you think the see-through display or non-see-through display would be best way of presentation of patient's imaging data during surgical procedure? Yeah. So everyone is saying about see-through display is the best way of presentation of patient's imaging data during surgery. So augmented head-mounted display projects imaging data directly into the surgical site. And in terms of augmented reality, before going into the augmented reality, I would like to discuss about reality virtuality continuum. So in augmented reality, it is a system where we augment the real situation with our virtual environment. And in the opposite direction, there is virtual reality. In the virtual reality, it is fully artificial, synthetic, and virtual environment. And in the middle, there is mixed. In the mixed reality, the user can have interaction with virtually enhanced environment. So in terms of virtual reality, it is completely synthetic environment. Real-time user can get the real-time perception when he is using artificial world. So it is mainly used for education and simulation purposes. And even virtual reality is mainly used for training of the aviation and health industry, so that users can perceive that what in the real-time situation he can feel with the virtual reality simulator. And in mixed reality, the real and virtual object will coexist. Artificial virtual object at that moment will interact with user, and it is used for in terms of medical teaching and even training evaluation. So in the augmented reality in the healthcare, it can show the patient's vital during the surgical procedure. It can project patient's imaging into the surgical site, and surgeon can directly interact with real-time patient's clinical data. So if we want to use the augmented reality in a spine surgery, what would be our steps? At first, we need to take the radiological imaging of the, and then we need to segment the data, that what part of the data we want to visualize through the augmented reality devices, and then we need to register the patient's data into the surgical site, and then visualization through augmented reality device. So if we look back that what are the ongoing practices that is currently happening for integration of augmented reality in surgery. As I am showing in this picture, there are two approaches that is people are currently using. One is two-dimension image recognition based integration, like this two-dimension QR code will be placed in the operating room. The surgeon needs to look at that image, and then patient's data would be visualized. And the second one is the fiducial recognition-based recognition. So over the patient's body, they will place different physical fiducials. The surgeon will look at the fiducials and will find the patient's imaging data. So what performance it is giving? Yes, it is bringing the patient's imaging data in the operating room, but it is less accurate to stabilize data during surgery. Because if I go back into my previous slide, if you look carefully, these two objects are going to be attached to the patient's body. So during patient's movement, during breathing, or during operative procedure, it is going to destabilize the data. At the same time, it is going to limit the surgeon's movement during surgery. And finally, it is having the QR code or fiduciary dependency in the surgical procedure. So what is our problem statement at this situation? In this situation, we have found that there is an unmet need to create a patient-specific augmented reality system which should be independent on any third object to enhance surgeon's performance. So in the interactive poll, I would like to take your opinion that would you consider use of augmented reality during surgery if it interrupts with your performance? You can give your opinion in the same poll. So everyone is saying that they will not consider augmented reality if it interrupts the performance, and that is in that context, we have tried to develop our surgical reality system, which is not interrupting with surgeon's performance. So our innovation was a spine recognizing hologram. So previously, I have discussed that what the procedure that is currently ongoing, it is based on recognition of QR code or the fiducials. So we have developed a system where we are going to recognize the spine directly through our HoloLens. So even if I use the patient's imaging data, it does not need to be dependent on any third object to recognize that patient's presence during the operating procedure. So in this development, we are going through 3 steps. At first, as I mentioned about the use of augmented reality in spine surgery, that 3D bone model has gone through a standard CT scan procedure. And then the main development about the novel algorithm to integrate into the Unity engine. And finally, the 3D CT scan model has been mapped into our HoloLens 2. And that means we want to visualize the 3-dimensional CT scan through HoloLens 2. So when we are applying that spine recognizing hologram through surgical reality system, we have found the HoloLens is directly recognizing the spine model. It does not need to be dependent on any third object. And the holographic model is superimposed and stable into the spine model. It is not having any stability problem during the movement of the surgeon. So I would like to share our lab model. So in that video, you are seeing that there is one model is showing. Actually, there is 2 models. The first model is our bone model, which is superimposed on our lab model. On that basic layer, we have developed our surgical reality system. And this surgical reality system, we have developed a unified coordinate system. Like previously, we have mentioned that the imaging data is giving us all the information in the 3-dimension coordinate, since we are using the 3-dimension CT scan. And this unified coordinate system is going to establish and project the hologram over the patient's body. So in our digital model, you will see that we have developed in the surgical reality system a way that we can project the patient's imaging data and can even superimpose directly over the patient's body in a unified coordinate system, which is stable. So this is our digital clinical model of the surgical reality system. When we look back into our comparative error rate, what the current ongoing system is doing and we are currently having, we have found that QR code-based recognition is having average error rate is 0.06 millimeter, where fiduciary recognition, the error rate is around 2 millimeter, and our surgical reality system is having error rate of 0.02 millimeter. That is our maximum error rate. So let's look on that ground, what would be the future of spine surgery. So at first, this surgical reality prototype can be integrated with surgical navigation system, and it can be used to predict surgeons' behavior. And in the third point, it will create a new dimension of surgical workflow. And overall, it will ensure the provision of the safe surgery. So in the future outcome, it will give the precision in spine surgery. It reduces the surgical complications, and it saves the operating time and cost during the surgical procedure. And here is our team member. Our lab, I am doing my PhD under the supervision of Dr. Antonia Arner, and Dr. Debe is also supervising that project on the ground of orthopedic surgery. So thank you everyone for your patience and for your presence. So we are now open for question and answer section.